and welcome to this Practicing Clinicians Exchange podcast series on multiple sclerosis. In this final episode, we'll explore the important topic of managing MS over the long term. My name is Allison Boyd, and I'm a physician assistant specializing in MS at Sentara Neurology in Virginia Beach.
And hi, Allison. I'm Dr. Stephen Krieger, professor of neurology at the Icahn School of Medicine at Mount Sinai in New York.
This program is supported by an educational grant from Genentech. Partners for Advancing Clinical Education is providing this activity for 0.25 ANCC and AAPA credits, with 0.25 pharmacy credits available for nurse practitioners. To receive your credit for this program, please go to pce.is/MS. I'll repeat this link at the end of the discussion as well. Our learning objective for this podcast is to help clinicians implement strategies to address comorbidities and long-term challenges to the management of MS. We'll share some practical strategies you can apply in your everyday work as a key part of the clinical care team. Dr. Krieger, I'd like to begin by having you talk about some of the most common comorbidities you see in your patients with MS, as this can often really rope in a lot of their long-term management as well.
Yeah, we think of MS as a disease that starts in young, healthy people, but not always in younger or healthy people. It's really a disease of the entire lifespan. And so at outset, MS can occur in the setting of someone with many other medical conditions and comorbidities, and certainly over the course of the disease, as we do a good job of taking care of people with MS and have their lifespan extend out for 40, 50 years, perhaps after their diagnosis, people are likely to accumulate comorbidities. So some of them are really literally MS related, and others are less so. In MS, obviously, it can cause things like fatigue and anxiety and depression and problems with sleep, which can certainly contribute to one another. MS can lead to bladder and bowel symptoms. Of course, MS can limit mobility, and for someone who has mobility issues, they may develop secondary arthritis or sprains or strains in a weak leg or hip, for instance. And people with multiple sclerosis, as we said, are entitled to have other diseases that are unrelated. But we know that cardiovascular disease, high blood pressure, diabetes, obesity, obstructive sleep apnea, all of these things are deleterious to brain health. All of these things can make people with MS progress faster, in a sense. So it's not like we didn't already have good motivation and rationale to treat these conditions and comorbidities, but particularly in the setting of a chronic neurologic disease like MS, keeping those comorbidities under control can be really essential. And I think this is where an interdisciplinary team and our nurse practitioners and PAs and other providers play a really essential role in managing symptoms and comorbidities. Talk to me, Allison, a little bit about how you do this in your own practice, both the things that relate literally to MS and some of these other things as well.
This is huge. And this is really, as an EPC, my bread and butter of what we do day to day. I like to think of these patients definitely as looking at the whole patient, not just the MS. As you said, everything is influencing their MS. And it's constant education for that as well, because patients often will say, well, it's my MS. I feel this way, it's my MS. Or I called this doctor, they said to call you because it has to be my MS. So it's really educating about the comorbidities and other things that may influence their MS. So I often will discuss with patients, or may ask them, have you had any relapses, or do you think you're having a relapse? They sometimes look at me and say, well, what's a relapse? And so we'll go through and really educate about true clinical or MRI relapses versus what we would consider a pseudo-relapse. So I'll educate patients that while they call me having increased numbness or spasticity, they get confused as to why I order a urine sample. And I have to explain to them that oftentimes we may see another type of infection, such as a urinary infection, which is very common with MS patients, causing an increase in their prior MS symptoms that may have been stable. So we're looking for the absence of other triggering factors such as infection or exposure to heat or significant stressors that may bring up symptoms for a patient that they had previously been at bay. We also want to tailor the treatments both for not only disease modifying therapy, but also symptom management for the patients individually. I often will go through all the patient. I say, I'm going to go head to toe with all the possible symptoms that you're experiencing. And we go through each and every one. And one of my follow-up questions, even if they're experiencing some type of symptom, would be, is this something that's bad enough that you'd want to take a medicine for every day? And if their answer is yes, then we go through those options. If their answer is no, then I just explain that that kind of helps me to gauge where they are with that specific symptom and helps me to kind of prioritize for their management of the day-to-day symptoms of what can actually help them feel better. I will often go through the importance of non-medication things such as diet, exercise, quitting smoking. There's been a lot of research that patients who quit smoking have better outcomes than patients who continue smoking through their disease course. And this can sometimes be difficult because patients may tell me, I've lost everything. All I have is my smoking. And so it's continued education of quitting smoking. I often will use the adage that, because everybody knows what's heart healthy. So I will often use, if it's heart healthy, it's brain healthy. Also, so exercise, aerobic exercise, but being safe with balance because these patients are at risk for falling. I do a lot of aqua therapy, which I think is great because I explain to patients that it keeps their body temperature down. So that allows them to exercise without getting that phenomenon where the elevated temperature will bring on more symptoms. And it also helps prevent falls. So patients can't fall if they're in the pool. It's a very good way to exercise and get them some physical activity. And then it's also having very difficult conversations with patients as they've done everything correct. They've followed all the directions, everything, and they continue to progress. I had this very difficult conversation just yesterday, actually, with a patient who was just begging me and crying not to have to use a wheelchair. So it was a very long discussion of explaining that the wheelchair would actually give her more freedom and more independence. So it's those very difficult conversations with patients that we can have after long-term management and really having long-term relationships with these patients to be able to effectively have those difficult discussions.
Yeah, I love all of these things that you're talking about because they are both problem focused, how can we address symptoms and concerns? And they're also empowering because these are things that people can do in their own lives to improve their well-being. To circle back to my favorite metaphor of this tank of reserve, I talk to patients about what can they do to keep the tank full? What can they do to fill their reserve? And I think things that you described, even physical therapy, occupational therapy, speech therapy, if they need it, are ways of filling the tank. Right? Why do people with MS get better after physical therapy? It's not an injury. It's not a post-op recovery. It's teaching the brain to do things in a more effective and more efficient way, working around some of these lesions. And I use all of those metaphors with my patients to try to encourage them to keep the tank full. I also use the idea that what we see in MS above the surface, right, what we see clinically is not the whole picture. And that what we're trying to do with our treatments is to keep the disease quiet, both that which we see clinically with symptoms and that we can picture with our MRI scans, to try to encourage people to be adherent to the treatment regimen and prevent things, even ones that we might not have known about clinically, adherence to the long-term treatment process. How do you talk to patients about this and promote adherence to a treatment plan, Allison?
Definitely think one of the biggest things is ongoing education about goals of treatment, be it the disease modifying therapy or symptom management, and making sure that our goals are matching up with the patient's goals. Because what I think may be a success, the patients may think is a complete failure. So the ongoing education, counseling, remaining in keeping the open line of communication with the patients, very, very important. Telemedicine, since the era of COVID, has actually become very helpful because we can touch base with patients more frequently And we can see some of the patients who may have difficulty with the distance of getting to the office. We can see them more regularly and keeping in touch with them, which also helps improve adherence, because if patients feel like we're all in this together and we're all working towards the same goal, they're going to keep taking their medicine because they feel like we're going in that direction. We're definitely a large team for each, MS patient. It takes a full team. Dr. Krieger, how do you work with nurse practitioners and PAs in your practice at Mount Sinai?
The place I work is the Corey Goldsmith Dickinson Center for Multiple Sclerosis, and we try to be as interdisciplinary of a program as we can be. Because we're in New York City, we don't have an enormous amount of real estate, so some of our allied health providers are not within our exact practice. So, for instance, our physical therapy group is over in the rehab area. I might refer patients out to things like urology, but we're trying to bring more of that into our practice with neuropsychologists and people who can help with counseling. But the one type of provider we have had at our center from the very beginning are nurse practitioners. And we've had nurse practitioners here in our center from the outset, and they see many of, if not most of, the patients at some point or another for clinical assessments, for counseling on disease modifying therapies, for injection training or first injections, talking to people about their infusions, of course, for managing MS symptoms, to some extent, managing comorbidities. There's always a fuzzy line between the comprehensive MS provider and the primary care role. So sometimes we take those things on ourselves, and our NPs have a really principal role in that way. I will say I try to have a very close relationship with my patients. So what I try not to do is offload the deep, meaningful connection onto anyone else. I like to have that for myself in my practice, but I think that patients can have support from a variety of people. And I think the perspective that advanced practice providers and nurse practitioners can bring into the room is different than what I bring into the room. And in that way, our patients really benefit. How about you and yours? What is your role in your practice with people with MS?
I think it's very similar that it's definitely a team approach. The doctor or I will see the patient as a new patient, and it's kind of set as a standard that we work as a team, and they may see either one of us or get either one of us as far as when they call in to the office or have a question or concern, but that we support each other and that we each bring different things to the table as well. I'm very careful about making sure that patients understand I'm not portraying myself as a physician, that, we are a physician APC team. And it helps to build that relationship in the long-term management for the patients. It also helps to bridge some of the gaps because we are, medical providers, but we're also human. So we're not always here, and our schedules and lives may, make some follow-up visits a little bit longer out than patients would like. So it does help to bridge some of those gaps, and being able to give the best care to our patients. And I just think some of the background training for nurse practitioners or PAs may be just slightly different than a physician. I always say that, more sets of eyes or different perspectives can definitely bring different things to light and ultimately make a better outcome. And then getting the families and the patients to understand that we're all really working on their team for them.
What other resources do you utilize or that other nurse practitioners and PAs can call upon to go beyond what they have at their immediate disposal to help take care of people with MS?
I definitely rely on a lot of the education put forth by the National MS Society. I will refer patients to the National MS Society Navigator Program, and they have individuals who can connect with patients and really delve into different needs that they may have at different points of their journey through MS. They can help with, home modification education. They can help with navigating the horrible process and huge process of applying for disability. So that's a huge resource for patients and family members for the education as well. We have a nurse within our office who can do some of the patient education. And if there's any community resources locally, sometimes there are still patient education programs. I always really try to encourage patients that the more education they get, the more empowered they will be. So we do have a lot of resources available that are very, very helpful. But I think the number one is the National MS Society.
That's great. I've also noticed for people who use social media with all of the pitfalls to be acknowledged about social media, but there is really a dynamic community about MS on Twitter, for instance, where people can get a lot of information, a lot of patient support. I've used Twitter a bit for professional purposes, but there are others who really put an enormous amount of good quality content there. So that's another resource to use carefully for people with MS and those of us that take care of them. So I think we're out of time with our third podcast in this series. Allison, why don't you give us the quick takeaway at the end of this third podcast? What's the take-home message you want our listeners to know?
I think that the most important thing is that we really need to recognize that from the time of diagnosis, we are with these patients long-term. We are often viewed as their primary medical care lead. And so we're there with them long-term for their treatment and management through their journey. Stephen, thank you for joining me today and for sharing your expertise. And I'd like to thank our listeners for taking part in this activity and remind them to be sure to catch the other 2 episodes in this series. To claim your credit for participating in this activity, please go to pce.is/ms and complete the post-test. Again, that's pce.is/ms. Thank you so much.